Hello, my name is Nina Shah from the University of California, San Francisco in San Francisco, California. We are pleased to talk about the results of health-related quality of life in patients with relapsed refractory multiple myeloma treated with Idecabtagene Vicleucel, also known as Ide-Cel, versus Belantamab Mafodotin in a matching adjusted indirect comparison study. Now, why do we do these studies? We want to understand if quality of life is different between two therapies when we really can't compare them directly in a head-to-head trial. As everyone knows, it's really important for multiple myeloma patients to have treatments that are effective in reducing disease burden, but there are also always side effects of these treatments. So it's important to know what the pluses and the minuses are. And sometimes it's hard to know those things that are different between treatments unless you do a deep dive for an analysis. So the purpose of this abstract, or the purpose of the study, was to look at the quality of life data that we got from the Ide-Cel study in KarMMa-1 and compare it to the DREAM2 study, which studied the Belantamab Mafodotin. For anyone who may not be aware, Ide-Cel is a BCMA-directed T-cell therapy or CAR T-cell therapy, chimeric antigen receptor T-cell therapy, where patients' own cells are engineered to attack the myeloma against a specific myeloma protein on its cell surface. Similarly, Belantamab Mafodotin also binds to BCMA, but it's an antibody drug conjugate. And so it's an antibody that binds to BCMA and has on it a warhead that's deployed specifically against these myeloma cells when it binds. So these are two different ways to treat myeloma. One is with an engineered cell therapy, and another is with an off-the-shelf antibody drug conjugate. Both of these have been studied in pivotal phase 2 trials, and both of them are FDA approved for patients with relapsed refractory multiple myeloma, Ide-Cel for patients with at least 4 prior lines, and Belantamab Mafodotin for patients with at least 4 prior treatments. So oftentimes practitioners are thinking and patients are thinking, which one would be better for me? There are pluses and minuses to each of these therapies, but we specifically sought to understand the differences in health-related quality of life, pain, and other symptoms that would be reported in the context of these studies. So this data was collected prospectively for each of these studies, both the KarMMa and the DREAM studies. And what we did was performed a match adjusted indirect comparison. This allows us to adjust factors for patients, what we call covariates, including age and sex and race and years from diagnosis, et cetera, these things that may affect how patients may do. We try to adjust and match the patients between the two trials so we can compare the outcome measures. We were really interested in 3 basic quality of life or patient-reported outcome measures. One was the global health status quality of life, which we measured with the QLQ-C30 questionnaire. Similarly, we were interested in changes in pain and changes in fatigue. We picked these 3 because they're very informative of how myeloma patients are doing and important as far as when myeloma patients may be making a decision of which treatment to get. What we know from the analysis is that when we look at quality of life, for example, we see that there were generally improvements throughout for the patients with KarMMa. And actually, if you compare from baseline at the start of the study, the patients in the KarMMa trial seem to have better increases in quality of life throughout the study versus the Belantamab Mafodotin. We looked at data from 2, 3, 4, 6, 9, and 12 months to look at this, understanding that, of course, these are data that we aggregated from the various studies, each of these studies, and compared against each other. And you can see that the patients, especially in figure 1B, that changes from baseline from QLQ-C30 global health status were actually favoring KarMMa over time versus the DREAM2 study, which is the Belantamab Mafodotin. Similarly, for scores about pain, it seemed that the pain happened to be more decreased for patients in the KarMMa study throughout, although this was more prominent in the later months like 4, 6, and 9 versus the Belantamab Mafodotin population. And this also was true for the patients for fatigue domain scores. They tended to also be better as far as less fatigue for patients in the KarMMa population in comparison with the patients in the Belantamab Mafodotin population or DREAM2 population. And that's seen in figure 3A and figure 3B. So there are differences that you may think that would be important. For example, would this still have held true if we look at the population that's just from the treatment dose that we are recommending? For example, in the Ide-Cel population, we recommend a 450 million cell dose. But as it turns out, even if you look at that factor, it's also true. Even if you can account for things like high-risk cytogenetics, extramedullary disease, it still turns out that the changes in the correct directions or the desired directions for the quality of life measures of quality of life, pain, and fatigue still favor in quantity Ide-Cel or BCMA-directed CAR T-cell therapy versus Belantamab Mafodotin. What does this all mean? It means that just in this analysis, and we can't say for sure, but just in this analysis, it seems that getting a CAR T-cell therapy versus an antibody drug conjugate, meaning getting Ide-Cel versus Belantamab Mafodotin, doesn't mean that you're going to have a worse quality of life from getting the CAR T-cell therapy. And in fact, it seems that if you look at comparisons of how patients did throughout the studies, patients who got the T-cell therapy may have had better quality of life, less pain, and less fatigue as time went on. Now, it's really hard to make these direct comparisons, right? Because we don't know exactly what's going on at each time point for each patient. And there may be some variables associated with each of these that makes the data that we see different, but not really related to the actual treatment. Of course, we also might find that this data is related to how patients did. And we know that in the Ide-Cel study, the BCMA CAR T-cell study, the response rate was greater than 73%, or greater than 70%. And in the BCMA-directed ADC or the DREAM2 Belantamab study, the response rate was closer to 30%. And so that might change what the output data is for quality of life. Also, we don't know, because we aren't the investigators on the DREAM2 study, what the baseline numbers were for the quality of life at baseline. And maybe these patients were sicker to begin with. All we know is that they started at a certain point, as did the KarMMa patients, and we used the data thereafter, how they did on the study beyond time zero. So it's really hard to make drawing or sweeping conclusions from this, but overall, it seems that the quality of life data favors Ide-Cel over Belantamab Mafodotin as far as improvements in good symptoms and decreases in bad symptoms. Thank you very much for your attention.